So for this video, we're going to be discussing the mobilization techniques or passive accessory motion assessment of the fibula, both proximally as well as distally. Let's start proximally. First thing we need to do is we need to look at the lateral aspect of the knee, recognizing that our fibular head is going to be found just distal to the joint line of the knee. And so if we can find the tibial plateau, we need to come lateral and distal to find our fibular head. Now this individual has a fairly petite, if you will, lateral leg. And so just visually, you should be able to identify the fibular head in this position. Also recognize that there is a degree of concavity and convexity that exists between the proximal fibular head and the tibia itself. The fibular head is kind of a spherical view, and so as we work to mobilize, it's not in a straight linear fashion, but instead it follows the direction of the tibia, and we need to be mindful of that with our position. So it's not going to be on a straight horizontal pathway, or if the individual was sitting up in a straight front to back motion. So with this, first we're going to start with an anterior to posterior. There's a couple different ways that you can do this. You can use a thumb over thumb technique. You can also use kind of a grip where you are coming into contact with your thenar eminence to the actual fibular head proximally. For most clinicians, those are the preferred two styles. So that you can actually see what I'm going to do, I'm going to use a thumb over thumb approach. So what we're going to do is we're going to find again our fibular head. We outline it here. Keep in mind on the posterior aspect, we have the common fibular nerve. And so if an individual is complaining of any numbness and tingling, or if you ask them to let you know that, that's important, because as you provide the posterior to anterior assessment, which we'll do in a moment, you don't want to compress that nerve. So at this point, I'm going to approximate my thumbs, thumb over thumb. You'll note the line of my forearm is not horizontal, but is slightly inclined up, and that's to follow that angle of the tibia. And so at this point, I'm going to provide an anterior to posterior force. I assess the entire motions available, and then from there, if I wanted to begin to treat this, I could break this into a graded mobilization of 1 to 4. The same can be done from the posterior aspect. And so if we walk around the back of the leg, again, we want to be mindful of the common fibular nerve, but again, we can use a thumb over thumb approach at this point, being mindful of our line of force, and here we can provide that mobilization as well. Again, assess all the way, and then you can grade it from there. There's probably somewhere, the estimations are between 2 and 4 millimeters of available range of motion at this joint, so there's not a lot. You're probably not going to feel a whole lot. So if you think about how do you grade the mobilizations of 2 to at most 4 millimeters of movement, pretty challenging. So really you can think of this as being either a grade 1-2 or grade 3-4 if you're using this as far as a treatment technique. Now, if we consider the entirety of the fibular bone, it really acts as a teeter-totter. And so I'm going to use my arm here to illustrate this. If I'm creating an anterior to posterior motion, in theory, the distal fibula is going posterior to anterior. And so we think that if somebody has lost or has a restriction of plantar flexion, and we've done everything else at the foot and ankle and have not regained it, we could come more proximally and look at the proximal tib-fib joint. In this case, an anterior to posterior mobilization would improve the plantar flexion range of motion. Conversely, posterior to anterior proximally would improve dorsiflexion at the foot and ankle. That's in theory. There hasn't been a lot of well-substantiated literature to back that claim up. The exact same setup and postures that we used proximally can also be used distally. The distal fibular head is a little bit easier to find. It is the lateral malleolus. Because of a syndesmosis that occurs here, there's not a lot of mobility that's here as well. And so at this point, same position would exist. We're going to adopt a thumb over thumb approach, and we're going to assess anterior to posterior, being mindful of line of force. Again, it's not a straight linear fashion, but slight rectilinear, you might say. And then we can also come from the posterior aspect, thumb over thumb approach, being mindful of line of force, and assess here. And you'll note as we do that, we can even create a little bit of a plantar flexion motion because those two would be compared together, would be occurring together. With this motion, you may also choose to assess this if an individual has had a high syndesmotic ankle sprain or a lateral ankle inversion plantar flexion sprain. Be careful as you do this. Our ATFL, CFL, and PTFL do attach here on the lateral side, and so there could be some tenderness, some swelling, some localized edema. Be mindful of your position and remain in close communication with your patient as you assess both proximal and distal tib-fib joints.